when it was written in 2017, the Quadratus lumborum blocks, the transversalis fascia block. These blocks are technically straightforward and relatively safe and reduce pain and opioid requirement in many clinical settings. The data supporting these outcomes, however, can be inconsistent because of heterogeneity of the study design. The extent of the sensory block is also somewhat variable because it depends on the achieved spread of the local anesthetic and the anatomical course of the nerve being targeted. The block mainly provides somatic analgesia and are best used as part of multimodal analgesia. This is purely for the TAP block. At the advent of QL block, then we became more somatic and visceral. So abdominal wall blocks, quickly we will just go into the important ones. The rectus sheath, the transesopdominous, which is divided into subcostal tap, lateral tap, and posterior tap. And if you combine a subcostal tap and lateral tap, you cover the entire anterior abdominal wall, the somatic distribution. Then you have the ilioinguinal, iliohypogastric, and the erector spinae block. So what are the indications? You practically almost every procedure that is done inside the abdomen, you can use the TAP blocks. And advantages of these blocks over the epidural is it's a very safe alternative. There is no motor blockade. There is no hypertension, unlike the neuraxial block. You can decide to go for a unilateral block. For example, if it's cholecystectomy, you can just go for a subcostal tap. And also liver resection, you can go for a subcostal tap. So less risk of neurological damage, and it can be done in high-risk patients, especially when they have sepsis or coagulopathy. So there is an interesting app. The app is available. I think everyone can download the app to understand the anatomy pretty well. And anterior abdominal wall, all of you know that there is this is the external oblique muscle coming in, and the fibers are moving downwards. Then you have the internal oblique, and then the transesopdominous. And this is the rectus abdominis. So these are the four muscles which give us a lot of insights when we do the interfacial plane block. And then I just want all of you to note the anterior rectus. So you see this tendinous insertion. So whenever you do a block, a rectus sheath block, it is between the posterior wall of the rectus and I'm going to come to it, but it's never anterior to the rectus muscle. It's posterior to the rectus muscle. But I just wanted to show since you're seeing the anatomy here, you never place the drug anterior to the muscle. And in the TAP, it's between the internal abdominal and the internal oblique muscle and the transesopdominous. This is an excellent schematic representation of what we see. So that is the skin, subcutaneous tissue, and you see the external oblique, internal oblique, and the transesopdominous. And here is where you deposit the drug in a TAP block. And then you see the other the muscles which are of great relevance to us. So that is the Quadratus lumborum that you see here, the erector spinae posteriorly, and that is the psoas muscle. This is an important diagram, and it's a simple diagram which all of us have to understand on using ultrasonogram. And all that is required is you just have to identify these three muscles, and you have to identify these three muscles for most of the interfacial abdominal wall blocks. So to quickly cover, it is actually, if this is a diagram representing the anterior cutaneous branches from T7 to T9. So any surgery that you are going to do in the upper quadrant of the abdomen, you go for a subcostal. Then when you do anything below, or when you go for a midline incision, then you need to do a subcostal tap and with a lateral tap. So T10, T11, and T12 will get covered by a lateral tap. So you need to do this plus this. So it's very important. This is a basic thing, but I wanted to clarify that if you want the entire anterior cutaneous nerves, spinal nerves to be blocked, it is just in a midline incision starting from xiphisternum to the pubic symphysis. It is always a combination of two tap blocks, subcostal tap plus the lateral tap. This is something which is very, very important. And also it's important that we know that this is another basic take-home message which I want to give. When the spinal nerve comes in, divides into dorsal rami and ventral rami. And when you do it in the thoracic paravertebral area, it blocks both. But if you see, it comes and then divides into three. Any spine surgery, you're focusing on the dorsal rami. And anything that you want to do for anterolateral component, you have to focus on the ventral rami. So this is another important point that I wanted to make it very clear. But also now it is understood that ESP block is, the more and more we study on the ESP block, when we place the ESP block between the transverse process and the erector spinae muscle, it has been found to spread to the thoracic paravertebral area. So that's why the visceral component gets enhanced, sometimes even in a ESP block. So this is just a reiteration of the somatic innervation of the anterior abdominal wall, and the nerves that are involved are the intercostal, T7 to T11, subcostal, the T12, iliohypogastric, and ilioinguinal. So, so where do you keep the probe for the various blocks? So here is the subcostal tap, here is for the rectus sheath, and here is the lateral tap, iliohypogastric and ilioinguinal is here. So now you use, for a rectus block, the simplest of the block, you use a high frequency linear probe, and you choose a needle which is about 5 centimeters. Majority of the patients, this would be sufficient. And when you put the ultrasound probe, you will see the subcutaneous layer, you see the rectus, and you see this hyperechoic line. So now all that we need to do is direct the needle here and place the drug between the rectus muscle and the posterior facial layer. I will show you So it's been found to be extremely useful in umbilical hernia surgeries, all midline incision, laparoscopic surgical port, tubal ligations, and so that's the anterior rectus sheath, the rectus abdominal muscle, and posterior rectus sheath. And so this is just to show, if you want to see both the sides, rectus abdominis muscle, the center is the linea alba, and that's the peritoneum. So why I wanted to project this is, when we do even simple blocks like this, should keep in mind that the peritoneum is very, very close by. And when you guide your needle, when you come in plane, you need to be very careful, hydrodissect, and it's important that you stop it here. So this is a very tough facial layer, normally difficult to penetrate, but I just wanted to take a message that when you do these blocks, though they are simple, you need to be extremely careful that you do not go and injure the peritoneum. So this is exactly, if you come in plane, this is how you deposit the drug. So rectus abdominis block can be done by everyone who are even not trained or have undergone a specific training, because there are no major vessels involved, and The volume that you need is we use either 0.2% ropivacaine or 0.25% bupivacaine, 10 ml on either side. If it is a pediatric patient, use 0.1 ml per kg per side. So this is regarding the rectus sheath block. Continuous catheters have been used, and we have used it very rarely, and just wanted to show one case where we had placed it for anterior, but this is purely somatic. But it's very important that this is helps the patient to do good chest physiotherapy. In abdominal surgeries, one of the things which prevents them from undergoing deep breathing exercises is the pain that arises every time that the diaphragm moves. So this simple one in midline incision, especially when it goes up to the zipisternum, this simple rectus sheath block would help the patient to take deep breath. So next we go to the transesopdominous, the plain block, and I've already described the muscle layers, like that's the external oblique, the internal oblique, the transesopdominous, and here is where you see the spinal nerve going here, and it is you see here, it's first it gives the lateral cutaneous branch, then the rami goes up, and then it gives an anterior cutaneous branch. So this is a particular thing that I just wanted to enumerate, how the ventral ramus of the intercostal nerve, and we need to know that these are the two twigs that need to be blocked in a TAP block. So next, see, this is this anterior cutaneous branch has also become extremely popular for completion's sake in the sternotomies. So all the sternotomies, if you go for parasternal blocks now, when we block the anterior cutaneous branches there, very simple again, it has been one of the important reason of fast tracking in cardiac anesthesia, and ERAS in cardiac anesthesia have incorporated this. So now we go to the TAP block. Right. So now the approaches. So when you want to give a subcostal TAP, you use a high frequency linear probe, and this is the ziphisternum, this is the subcostal region, and you just place the probe just below the costal margin, and what would you see? So these are the indications. These are the equipment. So the probe placement. Yeah. So this is the ultrasound image and you know that you need to place and always when you want to come in, you choose a plane like this where you would see, you see the difference between the internal oblique and the transesopdominous. You see that there is an area where you see an anechoic zone. This is the right place to bring in the tip of your needle, because you can open up this fascia very fast. So whenever you do a TAP, you do a scanning and see, you move the probe and just try to get into a potential space like this to place your drug. It will be very, very successful TAP block. So the local anesthetics that we use for a TAP would be 0.25% bupivacaine or levobupivacaine or 0.2% ropivacaine. Unilaterally, you may need about 20 ml. Suppose if just unilateral, you err on slightly more volume of 30 ml. Bilateral means you give 20 ml on either side. And if you want to do a subcostal TAP and a lateral TAP, then I think you need to place 10 ml in the subcostal and then about 20 ml. One of the things that you need to keep in mind is the total volume that you're using and the milligrams that you're using. So for a child, if you want to calculate, it's 0.4 ml per kg per side. So this is the commonest diagram that is used for a tab block, because majority of the time in the initial phases, you fail to deposit between the two fascia, and either it is into the internal oblique or into the transesopdominous muscle, and it won't work very well. So this is the ideal one. And you, as I said, you need to see the potential space and place the drug. So the reported complications include local anesthetic systemic toxicity, intraperitoneal injection, bowel injury, liver injury, and infection. So that's the area supplied for the subcostal tab, covers T6 to T10, analgesia from xiphoid process to umbilicus, hepatobiliary surgery, gastric surgery, renal surgeries, laparoscopic sleeve gastrostomy. So the way you keep the probe, supine, linear high frequency probe. Yeah. So you would deposit the drug. So that's the rectus. And this is the, so in two places you can do subcostal tab. So either you place between the internal oblique or transverse abdominis, or between the rectus abdominis and the transverse abdominis. So there are two types of subcostal tab that can be positioned, that can be deposited. So that's about the drug volume, which I already dealt with. And now we go to the next block, the erector spinae block. I'm just timing myself, and I think I'll try to be a bit more faster. Is the pace okay, or am I too fast, or is it?
It is perfect.
It is okay, sir. It is okay.
Perfect.
Okay, so next we go to the next simplest block, and I think this is something which each one of us can do if you have an ultrasound machine. And where do you deposit the drug? This is an excellent schematic representation of, you see the spinal nerve coming out, and that is the transverse process. This is the erector spinae muscle. Like what you see in the anterior abdominal wall 3 muscles, when posteriorly, when you scan, this is the spinous process and the transverse process. This is the skin. When you come, you again have 3 muscles, and we target the 3rd muscle, the erector spinae muscle, and you place the drug here. Now, predominantly, it works on the dorsal rami. But when the volume increases, it seeps in and also cover the ventral ramus. That's why there are a lot of publications which are coming in using ESP even for surgeries involving the anterior abdominal region. So next one, when you place the probe, I think it is very important for you to identify the transverse process. And this is an excellent diagram. This, you have to see like the capnograph image. It should be rectangle. And when you go slightly more laterally, especially in the thoracic region, you will see the rib, but the rib will be more curved and it will be like a convex. So at one point, you will see the convexity transferring into a rectangle form. This is the area where it is the junction between the rib and the transverse process. So this is what you see here in this diagram. So that is the costo-transverse junction. But simple take-home message, you see 3 layers here. This is the ESP, this is the transverse process, and all that we need to do is, you can go out of plane or in plane. You just come and hit the periosteum and inject the drug. Then you will see the drug spreading, and you create an anechoic layer here between the ESP and transverse process. And this is something which every spine patient should get it. And then this gives him the allowance to lie in normal supine position after a major spine surgery. So it can be done either in sitting position or it can be done in a lateral position. But most of the time, we do it after inducing the patient, positioning them prone, and giving it after he's anesthetized, but before the incision is made. So just to show that the skin, subcutaneous tissue, trapezius, rhomboid muscle, erector spinae, transverse process, and the drug deposition here. So most of the times we use a 5 centimeter needle, and either local anesthetic could be bupivacaine or ropivacaine, and volume you need is about 20 ml on either side minimum. Or if more segments are involved, we do 4-quadrant block. The usual block failure is because of not placing the drug in the right plane. And one of the things that needs to be kept in local anesthetic toxicity, and there are few case reports of the drug spreading into the epidural space, producing hypertension, but this is very, very rare. Yeah. So that's how you hit it. And this is an easy block to give. Next, we quickly go to one of the most fascinating blocks which has evolved now, is the Quadratus lumborum block. And when you do the scanning, as you go from, for example, umbilicus, you just take the probe laterally. So first, when you go laterally, first you will see the external oblique, internal oblique, transesopdominous. Then you see slowly, then you take the probe towards the mid-axillary line and to the posterior axillary line. And then you start seeing this transesopdominous. The muscle becomes a fascia. This is called the transversalis fascia. And where the transversalis fascia ends, you get the Quadratus lumborum. And based upon where you deposit the drug, it is divided into multiple terminologies are given. But for this, the ease of understanding, you can actually place the drug here. That is where the transesopdominous ends and the QL starts. So this is one place where you can give. And always you can choose this when you want it, when you're doing a surgery. For example, iliac crest harvesting, bone graft when they take, this is a simple block and can be done in supine position. You can use this and it's very, very effective. But when you wanted to go for a block which you wanted to go more towards L2, 3, 4, like for example, hip surgeries and abdominal surgeries where visceral component needs, somatic and visceral have to be involved, then you go for the block between Quadratus lumborum and the psoas muscle. And so you place the drug anterior to the Quadratus lumborum muscle. This is a very, very effective block. For if you want to do for major abdominal surgeries, when you want to make both the visceral component and the somatic component together, good pain relief, bilaterally, it will be the QL block where you place the drug between the Quadratus lumborum and the psoas. So this is an excellent block to learn, easy one and excellent block that you need to administer. So just to show that, see, this is the transversalis fascia ending here, that's the QL. So you either place the drug here for iliac crest bone grafting, you place it here anterior to the QL when you want both the visceral component and the abdominal component involved. So it can be done. If it's obese, then you have to go for curvilinear probe. If the patient is thin, you can do with just a high frequency linear probe. And patient is in, either you can do it in supine or you can do it in lateral decubitus. If it is in supine, you need to take the probe. Always QL blocks can be done easily when the patient is in the lateral decubitus position. Yeah. The next one, which I wanted to describe, is the shamrock. All of us who are doing the QL always talk about the shamrock technique. So the shamrock technique is primarily this is the vertebral body, and this is the psoas, this is the QL, and this is the erector spinae. So this is called the shamrock sign, which I wanted all those who are not using ultrasound to learn this. This is an important sign that we need to know. And this, again, the schematic diagram is very, very important when you see these three muscles. So those who are starting to using ultrasound, I would like all of you to track the transesopdominous muscle. Where it ends, go further posterior, and you see the QL starts. And it's a very, very simple block to give, provided we know what we are doing. And when we do in lateral decubitus position, you keep the probe midway between the costal margin and the iliac crest. And what exactly that you would see is this is the shamrock sign. And as we discussed, if you want to do a visceral component involved and you wanted a good block to be given for intra-abdominal surgery, you place the drug here. And if you want for iliac crest, you place it here. So this is the shamrock sign. This is the transverse process. This is the vertebral body. That's the quadratus lumborum, the psoas major, and erector spinae. This is exactly the sonoanatomy you will get in the lateral decubitus position, and the probe kept between the iliac crest and the costal margin. And you come in plane, and then you get the needle here. For those who don't, it's better to use a 10 centimeter needle for a QL block. For those who do not have the specified block needle, I think you can use a spinal needle, a 22 gauge spinal needle or a 23 gauge initially, but later you can go for a 25 gauge spinal needle. And you bring in the needle from here, and you look for this facial plane. So you deposit the drug here, and it will be an excellent quality of block. So look for the transverse process, identify these three muscles, and then you go for the anterior QL. So this is the transmuscular QL. And I would urge that if you work on placing the drug between the QL and psoas, and if you master it initially, this will be a great advantage to your patient in most of the abdominal procedures. And the volume that you need is about 20 to 25 ml that we deposit. So similarly, like other blocks, intraperitoneal injection, bowel injury, renal injury, you need to be very careful because the lower pole comes very close to the QL, and this needs to be kept in mind. And there could be lumbar plexus blockade because of the spread of the drug, and there could be quadriceps weakness. So when you advocate them to ambulate, you need to make sure when you do a QL block that you have to make sure the quadriceps is not involved. So I was timing myself, and I think I've taken slightly more than the allotted time that has been given to me. But I thought I will go very slow on some of the simple blocks which can be used clinically by all of you. So thank you very much for your patient hearing. And if there are any questions, Madam, can I take it now? Because I have to go to the theater once more.
Yeah, sure, sir. Sir, there are two questions at the moment. One is regarding the tab block. If there is a bowel injury with the needle, what will happen? This is a theoretical question that has been asked.
Actually, nothing. Specifically, the needles that you use, they do a micropuncture. Normally, nothing happens. You may not even notice that you made an injury. But in case if you're suspecting something, you need to actually monitor the patient for developing signs of peritonism and peritonitis. But it is very, very rare. It's reported in the literature, but not common.
Another question is mixing the dexamethasone with turbid. Is it okay, or dexamethasone the action prolonged will be the same?
Addition of dexamethasone?
Yeah.
Yeah, addition of dexamethasone in all our interfacial plane blocks have, as I said, the audit indicates that they have excellent pain relief for close to 18 to 20 hours. And this, most of our audits have been on spine surgeries because this is the one which we use the most. And the ESP is the very commonly used one. And the QL we use for hip surgeries and also for iliac crest bone grafting. Addition of dexamethasone, clinically, we find the analgesia lasting close to 20 hours.
The question is, can we mix it and even it is turbid, we can use it? Or can we give it heavy?
So the question is regarding, can we mix Dexa along with ropivacaine because the mixture becomes turbid, and should we inject the same mixture?
Sir, I'm very doubtful about this particular point because I've seen our consultants mix and I've never seen it getting turbid. So I've never seen it getting turbid. We mix the drug and use them.
Okay.
Okay. Thank you, sir.
Any more questions?
No more question, I think.
Yeah, there are some comments, but somebody is mentioning, sir, you have mentioned something about an app. Can we download that app, and which is that app?
Madam, I will send that to you and
Okay,
you
sir.
can put it in the group.
Okay, sir.
Yeah.
Hello, Dr. Bala. Dr. Bala, can I ask you a...
Yes, sir.
Dr. Bala, this erector spinae block you mentioned,
yes,
if somebody doesn't have an ultrasound, these things, can it not be done under CM guided or hit the transverse process over 2 to 2.5 centimeter away from the midline and inject the drug blindly?
Sir, definitely it can be done with the CM. But I would not advocate blind because we can't go by 2.5 centimeters because many times it's not so. But 100% this can be done under CM, and it is visualized. The transverse process is visualized very well under a CM, and those institutions which do not have USG, I think it's a great idea to use the CM and deposit the drug. Completely, I think it's something can be done.
That is the exact point which I also wanted to make, Dr. Bala, saying that it should not be done blindly and with some sort of imaging modality with this ultrasound or a CM, which is possible. And also all these interfacial blocks, continuous catheter techniques are also possible.
Yeah.
So that is one of the advantages of these blocks, that you can extend the analgesia for more than say 18 to 24 hours by putting in a catheter in those spaces and running it an infusion.
And sir, interfacial plane blocks are probably the most fascinating blocks because you're not targeting a nerve and putting the drug in a space. And with the more and more knowledge we gain about the facial planes, the spread of the drug seems to be much more cephalid, much more caudal than actually we think. And it is determined by several things, including patient ambulating, patient getting ventilated. Every movement produces drug spread. So this is something the patient also decides on the spread of the drug rather than the way we inject it. And also there are multiple mechanisms that has been come in, macro mechanism, micro mechanism, seeping of the drug. So this is going to be the next 10 years. A lot of fascinating things will emerge from interfacial plane blocks.
Thank you, Dr. Bala.
There is a question from Dr. Naresh Paliwal. Use of full concentration of drug 0.5% levobupivacaine for unilateral erector spinae block or surgical anesthesia. Analgesia. Can we use 0.5% levobupivacaine for unilateral erector spinae block?
Or surgical anesthesia, madam?
Yeah, analgesia.
Unilateral because every spine surgery is bilateral. And I don't see a reason why it should be done unilaterally. And I'm not, because it's a midline structure and it gets innervation from either side. It has to be always be bilateral.
Okay.
Hello. They must be meaning it for erector spinae for, say, hysterectomy, for a one-sided nephrectomy or
MRM, he has
something.
mentioned. He has tried it in MRM.
Well, one-sided surgeries, like not the spine, non-spine.
It's fine. One-sided surgery, definitely yes. Even for fracture ribs, one of the other high use for us is fracture spine, serratus anterior plane block and erector spinae plane block on arrival seem to be doing extremely good pain relief for fracture. Yes, one-sided, definitely yes.
Dr. Bala, good evening. You are practicing a lot of blocks in Ganga Hospital. Have you come across what is the percentage of infection and which is blamed to our blocks?
Sir, to be very frank, zero, sir. Nothing.
Zero. Okay. Because while giving block, we take a lot of aseptic precautions. But sometimes it has been observed as surgeons, they blame to our infection due to blocks. Is it so?
Sir, honestly, definitely we haven't seen one, sir. We have never had an opportunity to confront such a situation.
Okay.
One more question is there, sir. Is there any risk of priapism after erector spinae block, especially given at lumbar or lower thoracic level?
So far, we have never witnessed one, ma'am. We have never witnessed one.
Any more question?
Hello, sir. Hello, Monisha.
Ashit, sir, please make your please put your expert comments, sir.
Yes. To those who want to start the Quadratus lumborum block, as Dr. Bala has said, we have to deposit the drug between the psoas muscle and the Quadratus lumborum muscle. So to the beginners, even if you put the drug inside the muscle, that is Quadratus lumborum, the effect what we are going to get is almost equal to like what we get in putting the drug in between the two muscles. So even if we accidentally put the drug inside the muscle, it is going to give you the same results.
Yeah, this is, I agree, Dr. Ashit. I think this is one facial plane block. If you term it as one, you can go into the muscle and you will get excellent, but not for many other interfacial plane blocks. But in QL, yes. But I think as more and more literature are coming in, even for ESP, the nerves penetrate through the muscle. So even if we inject it into the muscle, maybe the effect may be good. So that I think we need to wait and see, and more clinical trials are needed.
Yeah, one more question is there, sir. You mentioned about an app which we can download. So which app are you talking, sir?
That's what I said. The whole app, I'll forward it to Dr. Manisha or to you, Anita. You can send it across to everybody to download. Yeah.
Yes, sir. Sir, another question is there regarding the use of cap.
Called the essential anatomy. It's called the essential anatomy, and I will just forward it to Madam.
Okay, sir. Thank you. One question is there regarding the use of TAP or ESP in cardiac surgery. What should be the level of injection of ESP, drug concentration and volume? And what additives can be added for prolonged action?
Actually, for the sternal incision, the sternotomy is the most painful. And now we have a clear description of parasternal blocks. I don't have pictures right now, but it's again something very, very easy to deposit. And this is much better than going for an ESP. Parasternal blocks are much better than going for ESP.
Avinash, are there any more questions? I can't see any.
Yeah, one more question. For MRM, which one is preferred by you, sir, for MRM? That is, I think, modified radical mastectomy.
See, actually, I'm not a person who does MRM, but whatever I speak will be more based upon literature. All these combinations have been tried. The gold standard still remains the thoracic paravertebral block, the gold standard for the surgery, MRM, but various combinations have been tried, pick 2 with SAP, with ESP, and multiple studies have come on various interfacial plane blocks, taking into account, and also the fact that you also get innovation from the brachial plexus, the supraclavicular nerves, the cervical plexus. So the breast innovation gets its supply from just not alone this, but it all depends upon whether you want to go for a simple mastectomy or whether you want to go for a radical mastectomy with axillary clearance. So it is like more like a mathematics. You will see what are the nerves involved and go and block all the nerves. There are plenty of studies regarding breast surgeries and abdomen and thoracic wall blocks.
Also, I think there is an excellent review about the analgesia and analgesic blocks for breast surgery. I think in RAPM Cup 2 or 3, 4 years ago. Wonderful review of all the blocks and the sensory innovation for the breast surgeries.
Thank you so much, sir.
Yes, sir. Thank you. We will proceed to the
Thank you
next.
So much. Yeah, sir, it was an excellent lecture. And our Zoom platform is of 100 only, and it is full. And I'm getting many phone calls because the YouTube link started a little late. So till that time, I must have received 10 phone calls and 50 WhatsApp messages why the YouTube link is not started, and so many of them are waiting in the logged in for YouTube and still not getting connected. So that's the great thing for us, sir. Your presence was a great thing for Maharashtra State Chapter ISA. If it is possible for you to join back again for discussion, we request you to join again after. I'll try, madam. I'll surely try, but I would like to hear the first few slides of Amit to see the Amit progressing as an excellent faculty. Sure, sir. May I request Amit sir to start his talk, please?
Thank you, Manisha, madam. Yes, I'll start. So, good evening, one and all. At the outset, I would like to thank Manisha Katikar, madam, for giving me this interesting topic. And this was the topic for me in Maharashtra ISACon in Solapur as well. And I was looking at my journey back then, there, and now. And lot many things have changed. So I am really happy to have this topic again. I am really grateful for that kind introduction by Sade sir and team of wonderful ISA members, including Dr. Anita madam, Dr. Avinash sir, Dr. Samir. And I am really blessed to have Bala sir as co-faculty with me, and happy to have mentors like Ashit sir and Satish Kulkarni sir. So thank you very much. Without wasting much of time, I'll start with the presentation. Greetings to you all from Ruby Hall Clinic. And I was planning to share a few things. The literature review, then some block strategies. And so I do not wish to divide this presentation as whether I have ultrasound or whether I do not have ultrasound, whether it is PNS block or ultrasound guided block. I mean, if you look at the whole anatomy and the clinical aspect, I am sure at the end of the presentation, you will be able to devise your own strategy for management. So I do not have a single answer for everyone. Everyone will have to devise their own recipe depending on the infrastructure, the skill set available, the surgeons which are comfortable with, and the type of patient. So there are multiple variables. So previously we were mainly into general anesthesia, and now we are more and more into site-specific anesthesia. So what has changed the regional anesthesia? And we have this buzzword. So whenever possible, we want to do local infiltration. We want to apply regional technique. We are going more and more towards periphery. It is opioid sparing, it is multimodal, and we have now site-specific, procedure-specific prospect guidelines, and we are more and more into motor-sparing analgesia. So this is how our regional anesthesia strategies are progressing. So my talk outline will include anatomy of shoulder and arm, then the analgesic options, because not every time it is for surgical anesthesia. So it can be under general anesthesia, and we have to give analgesic options. Then surgical anesthesia strategies I'll be discussing, some of the complications of interscalene block and RA strategy modification. 2 weeks back, I got a call from North India. I would not like to disclose the details, but there was a case of interscalene block in some periphery, and the block was administered with equal concentration of bupivacaine and loxodadrenalin, and patient had, became unconscious and all that. So it is a nightmare for anyone, and we wish to avoid all those. And what strategies we can take, we can modify so that we are safe. And then the whole RA literature is talking about Phrenix sparing strategies, so I'll touch upon that. Finally, the prospect guidelines are only available for shoulder arthroscopy, and so I'll give the insight on that and I'll conclude. So anatomy, when it comes to anatomy, there is this, all my articles are after 2019, and most of them are like 2021. So I've looked at all the recent articles so that we can have maximum benefit out of it. So this article tells about the dermatome, myotome, and osteotome. And if you look at any RA lecture, the more you have sound knowledge of sonoanatomy, anatomy, we are better and better with regional techniques. So we need to know where the shoulder dermatomal innervation, it is supraclavicular nerve when it comes to tip of the shoulder. That is why there is a role of either a selective supraclavicular block or a superficial cervical plexus block. Then we need to know the innervation of axillary nerve, then the intercostobrachial nerve, which is not part of brachial plexus. And posteriorly also we need to know where is the median brachial cutaneous. And so unless we know the dermatome, we are not sure about the skin incision. Now there will be surgeries which will cut muscles, and so we need to know the coracobrachialis, the biceps brachii, the supraspinatus, infraspinatus. So there are three muscles in front of shoulder, and these are supraspinatus, infraspinatus, and teres minor, and behind are the subscapularis and teres major. So we if it is a mega prosthesis or something like that, and if it involves cutting of muscle, then probably as an analgesia strategy, when we are planning for that, we have to look upon muscle paralyzing strategies as well. Osteotomal, yes, there are cutting, cancer patients. So we have the suprascapular nerve and mainly the axillary nerve, which is for osteotomal innervation. We need to know the course of suprascapular nerve, where it is in the subclavian perivascular area, where it is subomohyoid, below the omohyoid. So it is anterior approach to suprascapular nerve, and posteriorly near the supraspinatus notch, and so where we can block it posteriorly as well. Intercostobrachial is very, very important, and now people are talking about ultrasound guided block, and we have the thoracic part. So we have proximal intercostobrachial, where we block it at the thoracic area, and then again we have a distal intercostobrachial. Most of the time, most of us probably would do a local infiltration in this area, but with ultrasound the precision has increased. We need to know something about this trunk, the upper trunk, and a lot of literature on upper trunk when we talk about site specific anesthesia analgesia strategy, and how this suprascapular nerve moves out, and even in the subclavian perivascular area, it is quite lateral. So we need to know, and this is very important for shoulder analgesia and anesthesia. So innervation of shoulder, so major it is with the posterior cord, that is axillary nerve, and from the upper trunk we have suprascapular nerve. The minor contribution can be of subscapular nerve, the lateral cord provides lateral pectoral, the medial cord provides medial brachial cutaneous. Then there is intercostal nerve, which produces this intercostobrachial nerve, and we need to block with local infiltration. And also the cape region, that the tip of shoulder area, we need to either give a selective supraclavicular nerve block or a superficial cervical plexus block. Now, if it goes to the arm and cutting of biceps and coracobrachialis, then probably musculocutaneous nerve also has got a role. So shoulder analgesia strategy. So what we can think of, if we have done it under general anesthesia, yes, then I can go low on concentration like 0.2% ropivacaine or 0.25 bupivacaine with or without adjuvant like Dexa. And I can use a single shot block. It can be a single shot interscalene block, or nowadays people talk about upper trunk or around C5 and C6 nerve root. It can be a subclavian perivascular block where we are aware that the lateral aspect we are covering, which is suprascapular nerve. And so if that sort of a strategy is done, then it can be a good block. Infraclavicular block and costoclavicular block, there is this suprascapular addition should be done along with that. Suprascapular nerve plus axillary nerve, the isolated blocks can be given. Or nowadays people are talking about ESPB block at T2, and this is also one of the strategy. And recently there are 2 case reports on PENG block in shoulder area. We are aware of hip block and PENG, but nowadays people are talking about shoulder PENG as well. For long-term strategies like, very good quality of analgesia where we want continuous catheters, it could be an interscalene catheter. We have tried subclavian perivascular catheter, and we have placed the catheter in such a way that pericatheter leak does cover the suprascapular part, which is in the lateral. I will be showing you in the subclavian area, the lateral part where we have this suprascapular nerve. So it does work. So even if you have tried any of these block, and with multimodal analgesia, I think it's a good strategy. Use of liposomal bupivacaine and LIA. This is always to complete the list, but there are articles about chondrolysis with local infiltration if it is injected in the cartilage. So this is about the analgesia strategy. But when it comes to surgical anesthesia, we need a combination strategy. Previously, people are really not thinking on these lines, and they would say, okay, shoulder, so I'll give a very good interscalene block and it should cover everything. But as we look at the anatomy, I think we need to supplement it with few other blocks as well. So the base, yes, the base is formed by probably an interscalene or an upper trunk block. And if we are using subclavian perivascular block because we are good at it, then it can be combined with a suprascapular nerve block either anteriorly or posteriorly. Then for surgical anesthesia, we need to utilize combination of intercostal brachial nerve and also either a superficial cervical plexus or a supraclavicular nerve block. Shoulder PENG, 2 case reports. It has been used for surgical anesthesia in selected group of patients, but we are not sure. It is still an evolving block. And the blocks which cannot be used for surgical anesthesia is probably ESP block or isolated suprascapular or axillary nerve block. If we do, because we miss on many other parts like lateral pectoral, the subscapular nerve. So as we have discussed, looked at the anatomy, so only giving this at the periphery may not cover the whole of glenohumeral joint. So I was just Manisha madam also told me to cover the PNS aspect. I think the YouTube has got a very fantastic video by Dr. Bala Venkat sir as how to perform interscalene block, how to perform a superficial cervical plexus block at the midpoint along the posterior border. And also I have shown here the intercostobrachial infiltration. So we have to combine these two along with interscalene block for complete action. And I'm sure people are aware of it and we are practicing it regularly. Coming to shoulder anesthesia, there are other aspects as well, pre-op, intra-op and post-op, and we have to evaluate whether this patient requires surgical anesthesia, which is opioid sparing. So we can fine-tune our strategy, whether what should be the position of the patient. Then intraoperatively, are the irrigation solutions being monitored? How many solutions? Sometimes the patient complained of pain in neck or pain in chest because of absorption of too much of solution in arthroscopy. post-operatively. So this has not been covered with block or something. So irrigation fluid, whether it is with adrenaline or without adrenaline. So you have to discuss with the surgeon and duration of surgery. So other aspects, cold patient, all these aspects we have to cover. Today I'll be highlighting mainly on the regional strategies. So these are the different operations and what are the positions. So patient positioning is an important issue, and what much we have to discuss with the surgeon, and the traction and the pressure points needs to be covered. So now I am coming to the intercostal brachial block, which is with the recent advances of having it done with an use of ultrasound. And I never thought probably people are working so seriously on this, that this. So, but looking at the cadaveric studies, probably I thought this is good idea to share with you, because the precision and accuracy will definitely increase. So proximal intercostal brachial nerve block is similar to that of a PEX2 block, where the drug is deposited between pec minor and the serratus anterior at second and third rib around 10 ml. And the distal, intercostal nerve block is in this fascia. It is axillary brachial plexus block. So it's at the same position. We go more caudal from the axillary artery. We see the latissimus dorsi just by the side of humerus, and over the latissimus dorsi in this crease. So mainly with conventional local infiltration technique, what we do near the axillary crease is the distal, intercostal brachial plexus block. Now, this was a hybrid technique. Now people are, nowadays you started utilizing combination of blocks to have desired effect and without causing much of complication. So instead of giving a single bolus big injection of bigger volume, why not divide it and have desired effect? So this was a recent article, and this was during the COVID times by Tognu and Andrea Tognu, where he has combined interscalene block with a supraclavicular and used around 30 ml. Now, this article was, this combination strategy is also, there was this article from Bala sir and his team, where they have talked about scapular surgeries, and they have talked about select and combined dual injection, triple injection. So this trend has changed, and we have started looking at the sonoanatomy, the dermatome, the osteotome, and we have started doing a low volume, low concentration, selective injections and combination of injection. So in my technique, more or less what I use is this block, and this is inspired from, this was an article by Dr. Manoj Karmakar, and he said this is a selective truncal block. And what he has done is first injection in the periplexus area near C5 and C6. So in my day-to-day practice, I use this strategy very often. And around C5 and C6, I just tend to deposit around 5 or 6 ml of local anesthetic. And the second injection is usually near the corner pocket. And what is the advantage of, and total volume is around 25 ml. And this combination strategy, along with a supraclavicular or a superficial cervical plexus block and intercostobrachial, will help and finish the surgical anesthesia for shoulder surgeries. The another advantage of using this subclavian perivascular block is it is like an upper spinal of upper limb, and therefore the surgeons are very happy because they get very good relaxation. Otherwise, if we do only a selected shoulder block, and then they may have difficulty in movement, and surgeon will think that probably the block has not acted, though there is a very target specific anesthesia, analgesia. Surgeons are most often not happy. So combination of either a costoclavicular, infraclavicular, or a subclavian perivascular is good addition to achieve that requirement, to meet those requirements of surgeons. So this is a selective truncal injection. So around C5, C6, we can just go paraplexus, mainly on the scalenus medius side, so that we are away from the phrenic, and we deposit very low volume, like around 5 or 6 ml, not more than 10 ml. And this will serve the purpose. It will not cause any hoarseness, any horror, any other untoward complications. So we are free from complications of interscalene block. And then lower down a corner pocket, which we are very used to with the combination, will cover the middle and the inferior trunk. So this has covered the superior trunk, the middle trunk, and the inferior trunk. and this block serves, it is like an all-purpose block as described by Manoj Karmakar. So what are the complications? Now I am highlighting on the complications because interscalene block is done by all the anesthetists. May it be novice, may it be expert, and complications are sometimes very, very critical. So one of the complication is at the time of needling, whether it is with PNS or with ultrasound, the dorsal scapular nerve, the long thoracic nerve, which lies in the middle scalene muscle, can get damaged. The black areas, these are the hypoechoic areas, and these are nerve fascicles, and we should not pass the needle within those compartments. It can cause nerve injury. Now, as we see C5 and C6, so traffic light sign, but this may not be exactly C5, C6, and C7. There may be anatomical variation, and the C6 dividing into two. So when we pass the needle between these two, it could be an intrafascicular injection. So it is good idea to do a paraplexus block instead of intraplexus. So don't bring the needle from middle scalenus and going towards it. Instead of, it can be done with an out of plane technique, and the drug can be deposited between the brachial plexus element and the middle scalenus muscle. So we need to know. So this was an article which showed that what is the anatomic basis, and it is not like C4, C6, and C7. It could be fascicles dividing C5 and C6 dividing into two. So I was talking about intraplexus and paraplexus. So bringing the needle in plane and going within the two hypoechoic area, this intraplexus technique may be disastrous, and we should be conservative with our needling, and paraplexus is a welcome idea. So what are the list? List is, I think most of us have seen most of these complications like phrenic nerve palsy, recurrent laryngeal nerve palsy, sympathetic chain involvement causing Horner, and there is sympathetic chain irritation can cause to, it is opposite of that of Horner, and sometimes intrathecal space is at 3.5 centimeter and epidural space is at 2.5 centimeter. It can also lead to it is a highly vascular and many vessels are there, usually the transverse cervical artery, the vertebral artery, and it can lead to last, and one should be very, very careful. Hematoma is known. Pneumothorax is also known if inadvertent needling is done by a novice. So I'm just sharing this video to show where the drug all can go in an interscalene block. So I'm bringing my probe to the midline, and you can see the trachea, yeah, and by the side of trachea, here you can see the esophagus. Now, how to confirm the esophagus? You can always ask the patient to swallow, and you will identify the esophagus. Usually, it is on the posterolateral aspect. Now, between the tracheo-esophageal groove, there is a recurrent laryngeal nerve. So, if drug has gone that deep and it has gone into this tracheo-esophageal groove, then it can lead to hoarseness of voice. Sometimes this is really annoying, and we do not wish to use that much of volume. So also where all the cricoid pressure we are giving, that also can be confirmed, and this is another aspect. When the drug has come below the carotid, that is the sympathetic chain alignment, and if the drug is deposited here, if it has accidentally gone there, then it leads to Horner syndrome. Now below the sympathetic chain, this white hyperechoic thing is a longissimus coli muscle, and behind the longissimus coli muscle is the vagus nerve. So sometimes there can be little vagal blockade. So some patients may have little rise in pulse rate after giving an interscalene block. So probably the drug has blocked the vagus as well. So this is for the Horner, where it is exactly below the carotid artery, and behind the longissimus coli, this muscle is vagal blockade. So these are some of the areas which we need to know. So what are the modification after, as I have discussed so many things till now? So what is the strategic modification we can think of? So it is good idea to use ultrasound for interscalene block, because in my practice of last 10 years, I think I haven't used even for a single patient an interscalene block volume more than 10 ml. It is always 6 or 7 or 8 ml, but never more than 10 ml, because I have supplemented it with a corner pocket block as well. And so no complications. So those are gone are the days when people say that you patient has Horner, patient has hoarseness, it means you have done a perfect block. I think we should not look at promote this type of practice. It is always annoying to see these things. Limitation in the drug deposition, as I was highlighting. So I don't put my needle deep down. I just aim at first two hypoechoic areas only. So therefore, going down up to vertebral and causing an intrathecal or an epidural is never a problem with me. So I do out of plane a periplexus LA deposition between scalenus medius and the brachial plexus, and therefore the damage to dorsal scapular or to long thoracic is often avoided. Volume I usually limit to 8 or 10, less than 10. So depending on the patient, it can be even 5 ml. Low concentration, so 0.276 to 0.3% is just enough to cause surgical anesthesia. In my department, we produce, we have this stock solution where we make it with an equal concentration of bupivacaine or ropivacaine with lox with adrenaline, and we add either 10 or 20 ml of NS. Yes, hello. Yeah. So, okay, I'll quickly finish this. Hello, can I proceed? Yeah.
Please, please.
Yeah, so use of color Doppler is good idea. Aspirate, inject very slowly, and surgical anesthesia can be achieved with multiple injection instead of single injection with large volume. So Phrenix sparing strategies is very commonly discussed topic in all RA conferences, and we should be careful in all these interstitial lung disease patients, CKD patients, and patients with respiratory compromise. So there is good evidence we should take proper care, and even 25% decrease in functional residual capacity, and it can be detrimental to the patient. So what are the strategies? I was just trying to show the video for diaphragmatic assessment, because phrenic nerve, if we want to assess, we have to see the diaphragm moving bilaterally. So we can see whether it is blocked or not, and we can quantify it. The other way is by excursion. So we can see the excursion of diaphragm with inspiration and expiration, and we can quantify it. Thirdly, there is assessment of diaphragm with diaphragmatic thickness, and we can see that with inspiration and expiration, the inspiration, the thickness increases, and expiration, it decreases. So when it is less than 20%, it is diaphragm is affected. So what are the phrenic sparing strategies? One, go on low on volume. We can dilute the local anesthetic. Then we have to move away from the target. We have to look at the anatomy, as I have shown you in the cadaveric dissection, how the suprascapular nerve is far away. C7 nerve block, selective nerve block, or suprascapular or axillary is the best strategy. This has been mentioned in the latest edition of Hedzik. There is a description about scud block, which is a combination of supraclavicular nerve block and an upper truncal block. There is also called as cut block, which is a costoclavicular plus upper truncal block. Lateral infraclavicular can be mixed with suprascapular. So these are going more and more towards periphery. There is mention about shoulder pang, superior trunk block, ESP at T2, and selective truncal block as I commonly practice, plus corner pocket. So various strategies are there. We need to know where the phrenic is, and I think the phrenic nerve, as I can show you, this is the anterior scalenus muscle, and just on the top of it, you can see this black hypoechoic area. This is the phrenic nerve. This is the middle scaling muscle, and this is the interscaling groove with brachial plexus element. So we can distinctly see the phrenic nerve in many of the patients, and we should have sound knowledge how to avoid spread of drug. Now, this was the article by Dr. Diwan, where he has used, initially this erector spinae block at T2. In my personal experience, one should be careful while performing ESP at T2, because pleura is very close. The T2 vertebra itself is very small in size, and requires good amount of dexterity. We should not inject the drug very fast, because it can cause cervical epidural. And we should watch and monitor these patients, and volume should be limited to less than 12 ml. If we use 20 and 25 ml, it will definitely cause cervical epidural. But this is a good strategy. When people have used this to its full extent, there was development of Horner's and facial numbness. So continuous catheter at high thoracic level should be done with. Costoclavicular block is the safest to cause no phrenic paralysis. So it is often used along with, this is probably, if I am asked to do a phrenic sparing strategy, my choice would be a costoclavicular block with combination of a posterior suprascapular nerve block. And as you can see, this posterior SAP arrangement and upper trunk block again is the strategy. So in upper trunk, we have SPA arrangement, 1, 2, 3, anterior and posterior division, and this laterally moving is the suprascapular nerve. So we deposit the drug just below the omohyoid, and we achieve this. So even upper trunk is enough. C5, C6 is blocked, and as you can see, anterior and posterior capsule are with C5 and C6 nerve root. So upper trunk is enough. So I am just showing you how the suprascapular nerve will look like. So here is the suprascapular nerve, and it is seen as a triangular thing, a small triangle like thing. It is seen on the top, and as we scan it down, the nerve moves laterally, and we see a hypoechoic area more and more laterally. So in the subclavian perivascular area, the lateral most hypoechoic area is the suprascapular nerve. You can use PNS and stimulate it and confirm its identity. So in a subclavian perivascular area, the red arrow is actually the suprascapular nerve. And if we were planning for a shoulder analgesia, we have to put local anesthetic somewhere down there. So what is the maximum drug which we can use for an anterior suprascapular nerve? So if we put 4.2 ml there, just below the omohyoid in the subclavian perivascular area, it probably will not cause any phrenic involvement. But if we go more than that, probably there is a chance that it can cause phrenic involvement. So around 5 ml drug is just enough. Now coming to the this last block called Teng block, and people have used it, and the drug is deposited just below the deltoid. You can see the probe position, and this is the subscapular tendon, and the drug is deposited between the subscapular tendon and the deltoid, and it is like an IPAC block where all the nerves supplying the glenohumeral joint are bathed, and it produces good surgical anesthesia as well as analgesia for selective arthroscopic procedures. So it is a motor sparing block as well. So I'm not going into greater details of, I've done these blocks, the axillary nerve block, not the axillary brachial plexus. So this was our OPD patient of frozen shoulder, and we have done an, the suprascapular, the posterior approach in that the notch, and with dual mode, and we have stimulated it. Axillary nerve, because these two blocks have arteries and then the vessels by the side of here, the dorsal circumflex humeral artery, and by the side is the axillary nerve. So again, this block is easier. If you are interested, then many YouTube videos are also available, and it's an easy block, and you can do it with a dual mode. PNS gives good conviction that this block is working well. So this was our patient who has undergone proximal humerus, and we have placed a subclavian perivascular catheter, and the catheter was placed in such a way that it involves the suprascapular component in the subomohyoid area, and we have placed a balloon elastomeric pump. Patient did not require any analgesia for next 72 hours, and it was multimodal analgesia with block strategy, and patient was very happy. So it helps in ERAS. No PONV, no breakthrough pain, use of catheter is highly desirable, could pass urine, had a good night's sleep, and multiple advantages with regional combination. So last but not the least, there are prospect guidelines, and we follow prospect guidelines because they look at a lot of meta-analysis and Cochrane review and review articles. So this is only for rotator cuff repair, and it is in 2019, and it recommends use of COX-2 specific inhibitor grade 2, grade D, paracetamol grade D, IV dexamethasone grade B, and in regional anesthesia strategy, continuous interscalene block is grade A recommendation. Single shot block is again grade A recommendation. And suprascapular nerve block with or without axillary nerve block, this is grade B. And post-operatively, it is again the combination of paracetamol and opioid for rescue and NSAIDs. So conclusion, interscalene block is not free from complications, so use less volume, and I think it's a very good idea to stick to less than 10 ml. Use dilute local anesthetic concentration. Surgical anesthesia can be very well achieved with even 0.3% of ropivacaine or bupivacaine. Interscalene block with, if you really wish to extend analgesia, add adjunct or perform the block next day, or you may use a continuous catheter technique. Interscalene block with ultrasound guided guidance reduces complications. Combination strategy of block and dividing the drug and planning the anesthesia depending on the patient and the surgeon and the infrastructure and the skill set available. So you can have your own recipe. Sound knowledge of anatomy is the cornerstone of success. Recent advances are upper trunk block, selective anterior suprascapular nerve block, PENG block, and Phrenix pairing strategies. So thank you very much for your kind attention. I welcome you all to AORA, ASORA, and there will be discussing a lot of regional anesthesia. Please do enroll. Thank you very much.
Thank you so much, Dr. Amit. It was an excellent presentation, though I did not though I did not give anesthesia to shoulder surgeries, but I could understand so many things, and especially about the PENG block to the shoulder. That was also a new thing for me, because I know PENG block for hip surgeries, but for shoulder was a new thing for me. Thank you for that excellent presentation. There is one question. One was regarding PENGs, so you have already mentioned that. Another is how you execute intercostal brachial nerve block at proximal level in thorax, especially with ultrasound.
Yeah. So I think I have mentioned there is this article which I think I can forward you also, but more or less it is similar to that of a PEX2 block. So the drug is deposited between the pectoralis minor and the serratus anterior at second or third rib. So it will cover the nerve definitely if we do it at that proximal level. There was this discussion by Professor Manoj Karmakar where he is talking about pectoral plexus of nerve, and he said that in that PEX2 area where just below where we deposit the drug, it gets multiple connections from the intercostal brachial, then the lateral pectoral, the medial pectoral, and it produces dense analgesia. So this is a strategy. Though I haven't done it, usually most of the time the distal intercostal brachial does suffice. So I'll always ask my surgeon, where is your incision, and ask them to mark the incision. And then I am ensure that, the nerve supplying by inverted U infiltration usually is sufficient. Thank you.
Thank you so much. May I have expert opinions from our auditors for today's session,
Yes.
Dr. Satish sir and Ashit sir?
Ashit.
Yeah, Dr. Ashit, you can start.
Ashit sir, are you there?
Yes, very much.
Please comment your expert comments on this talk.
I just wanted to, he has already told about that, but while doing the shoulder surgeries, the common incision taken is between the deltoid and the pectoral groove, that is deltopectoral groove. So this is the commonest area which is paired while giving interscalene block. So giving a block of T2, that is intercostal brachial, is very important while doing surgeries, specifically when they put the plate in between this deltopectoral groove, taking an incision at the deltopectoral groove. Secondly, I just wanted to add about the sparing areas, which he has already mentioned, but the most common area which is spared while performing a surgery on the upper arm is on the posterior aspect when we do a surgery of supracondylar area, at the supracondylar area. So this area should be infiltrated with local anesthetics.
Yes, perfectly right, sir. Also, if we are planning for a shoulder arthroscopy, then the posterior port again is with the thoracic dermatome. So local infiltration at that area would be an additional thing which is not part of brachial plexus. Thank you.
Thank you, Dr. Amit. Amit, I would just like to ask you one question.
Yes, sir.
It was commonly said that interscalene brachial plexus block should be done awake or under very light sedation.
Yes.
What are your views about doing them under anesthesia or awake?
Yeah, I think
The interscalene brachial block.
if I'm not wrong, 2011 FDA guidelines have come and which has clearly mentioned that this block has to be done in awake patient, and it differs when it comes to pediatric blocks, and pediatric is a different ball game altogether. But definitely, because we know the spectrum of complications, that even if drug is injected inadvertently, it can go into intrathecal space, it can go into epidural space. Many patients had local anesthesia, systemic toxicity. It can inadvertently go into the vascular space, and plexus injuries are also known. And there are case reports where continuous interscalene block was placed, and patient was found dead next day. The catheter has migrated into the intrathecal space, and more volume has gone in. So we have to be very, very careful. And whenever I'm planning my strategy, at least interscalene block I would like to perform when the patient is awake. And if I am asked to do it when under general anesthesia, probably I will not do it, or then I'll be very, very skeptical. Sometimes block is not the only answer. Safety comes first, and there are multiple ways of managing pain. Let's not be sorry. It is better to be safe than sorry. And I would strongly advocate that it is good idea to do it with an awake patient. And even if pediatric patient, unless you have this special training in that area, I think we should not venture into it and should not take it so lightly. Thank you.
I agree, Dr. Amit. Thank you very much. And also, I wanted to mention one about reversal of these blocks, which has also been mentioned.
Yes.
If at all, if you end up having a phrenic this thing and some sort of respiratory discomfort, injecting normal saline would
Yes.
rapidly reverse the amount of block, because with the dilution of the local anesthetic at that C5 or C6 level, you will get reversal of the nerve block as well, isn't it?
Yeah, people have described block reversal with interscalene block, and normal saline of around 10 ml is used. And it has also been said about reversal of high thoracic ESPB catheters, which are used for shoulder analgesia. If patient develop Horner's or facial numbness, then they have injected through the catheter around 10 ml of NS, and ESPB was also reversed. Yes. Yeah. So another strategy could be we can selectively use short-acting local anesthetic for interscalene block, and then lower down we can use. So drug combination can also be variable, and we can plan it. This was all more prominently discussed during COVID times, where people do not wish to have that phrenic block. Thank you.
And also in high-risk patients with comorbidities, and especially respiratory comorbidities.
Correct.
And having the lower. So I think the single most factor is the volume, the amount of volume we inject.
Correct.
And there is sufficient data that if we inject more than 8 ml at the interscalene, the chance of having a phrenic nerve blocker is near 100%.
Absolutely.
More than 8 to 10 ml, it's 100%. Less than 8 to 10 ml, still there is a small incidence. But if you go lower down, then obviously the incidence of phrenic blockade does reduce. Obviously, again, depend on the volume.
Any more questions in the chat box? I think there is one more question. How much Dexa can be added when the total volume is around 8 ml, especially for interscalene block, and how long it will last?
I think I can answer depending on the articles and review, but we have, because I know Dr. Kulkarni sir has done one thesis. Sir, would you like to
Yeah, I would answer that. Generally, most of the people describe is that 8 milligram dexamethasone added to the interscalene, and there were a lot of studies about 8 milligram versus 4 milligram. So we did a study as a part of the thesis topic for our DNB student, where 3 groups were there. One group had 8 milligram added, the other group had 2 milligram added, and a third group had no dexamethasone added. So without the control group. The control group average duration of analgesia, we had general anesthesia for all patients, and these were for analgesia following shoulder surgeries. The average duration was about 12 to 14 hours or about 15 hours. And when dexamethasone was added, the duration increased anywhere from 2 to 4 hours. So it came almost up to 18 hours. And in some patients, we got almost up to 22 hours. The big finding which we had that there was no difference between 2 milligrams and 8 milligrams dexamethasone. So if at all, if you can get away with 2 milligram dexamethasone, why add 8 milligrams? That was one. That was one of the main focus of it. Because high dose dexamethasone added perineurally have been shown to cause some sort of damage. When I'm saying high dose, it is almost more than 36 milligram. That is again in animal experiments. There are no human experiments. In animal experiments, when high dose dexamethasone was injected perineurally, there was damage. There was some sort of microscopic or histological evidence of nerve damage. So our point was to prove that 2 milligram is equally effective than 8 milligram. That was one. And secondly, with addition of perineural dexamethasone, the duration did get prolonged. However, it is interesting that whether you use IV dexamethasone, it is almost sort of similar, though this point keeps on going to and fro. Sometimes the studies showed that equally IV. Then if something is equally IV is effective compared to perineurally, then why add perineurally and add one more drug? Because somewhat dexamethasone is not licensed to be used perineurally. This is off license indication what we are using. And dexmedetomidine has been shown to be very, very safe to the nerves. So now we have this thinking about multimodal adjuvants, like dexamethasone, dexmedetomidine combination. There are some papers about that as well, and prolongation of analgesia almost up to 24 hours. Does that answer the question?
Yes, sir. Yeah.
Yes, sir. Yes, sir.
Any more questions?
How you will explain the axillary block?
Yeah, so this is a axillary nerve block which I have mentioned, and it can be used in a combination with suprascapular nerve block. So axillary nerve block is different from axillary brachial plexus block. So here the patient is is asked to remain in sitting position, and the probe is placed just behind the shoulder in the long axis. And we try to look at the surgical neck of humerus, so which can be very clearly seen on ultrasound. And at the surgical neck of humerus, there we have dorsal circumflex humeral artery, and just adjoining will be the axillary nerve. So when we see a pulsating structure on the surgical neck of humerus, we use dual mode, and we pass the needle, and as it goes near the artery, immediately adjacent to it is the nerve, so we get a twitch of deltoid muscle, and once we get the twitch, we reduce the current to 0.5 milliampere and deposit the drug. So isolated axillary nerve block is not commonly done, but it is always done in combination with suprascapular nerve block, and it has been found to provide good quality of analgesia, though the king of analgesia is interscalene block, but around 70–80% this combination along with multimodal analgesia is a reasonable option. And it is definitely Phrenix sparing.
Ashit sir, you want to add anything? Dr. Ashit Mehta?
He has covered almost every aspect of block for the upper arm and shoulder. So the things which I wanted to highlight it, I already talked about.
I think Amit, that was an excellent presentation and a very good cover of review of all the literature as well as the blocks for shoulder and the upper arm.
Yes, very true. Very true.
Thank you.
So if there are no questions, we can end the session.
Thank you, madam.
Yes.
Avinash sir.
Thank you. Thank you very much. Excellent talk and presentation by both the today's speaker, Dr. Bala Venkat sir and Dr. Amit sir. I thank both of them. I also thank to our today's chairperson, Dr. Ashit Mehta and Dr. Satish Kulkarni sir. Thank you very much to all who attended this meeting.
Before we stop, I just wanted to say one thing. We are all looking forward for you all to come to Mumbai for this AOSRA international meeting this September, October, where more of these areas and more of other blocks also will be discussed, both ultrasound guided as well as PNS. So please do look at the scientific program on the website, and we are really looking forward to host you all.
Thank you so much, sir. Thanks a lot. Thank you all for joining this webinar. Let's meet again on this Sunday for a celebration of Yoga Day on the platform of Maharashtra State Chapter ISA. Thank you. Thank you all.
Thank you.
Thank
Anita
you.
madam,
Thank you, everyone.
please stop the recording.
Yes, I will.
Okay, thank you.
Thank you.
Thank you. Thank you so much.
Thank you all. Thank you all.
लाईव्ह स्ट्रीमिंग पण थांबवा.
Should we leave? Avinash sir,
Yes.
should we leave?
Yes, sir.
Thank you so much.
Okay, good night.
Let's meet on Sunday at 7 o'clock.
Yes.
Yeah. Okay.
अविनाश सर
हाँ बोला.
करू का मीट?
हो.